Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you to my interview with the authors of an important article which will appear in the June 2025 edition of the Journal of Rheumatology. Today, I will be speaking with Doctors Anushka Aggarwal, Maha Almackenzie, and Rohit Aggarwal on behalf of all the authors of our featured article titled Role of CD19 Chimeric Receptor T-cell Therapy in Idiopathic Inflammatory Myopathies. And I want to thank the three of you for taking the time to speak to me and our listeners on behalf of the authors of your paper and discuss the important findings. So with that, we'll start. So could you please give me, just for the audience, a little background on the rationale for the use of a chimeric T-cell receptor antigen therapy, or CAR T-cell therapy, in idiopathic myopathies?
Sure. Maha or Anushka, do you want to chime in
Yes,
first?
sure. I can get this question. So the chimeric antigen receptor, or CAR T-cell therapy, is a groundbreaking immunotherapeutic approach initially developed for hematological malignancies. It involved genetically modifying patient T-cell to express a receptor that targets specific antigen, more commonly CD19, on the B-cell. Upon reinfusion, these engineered T-cells recognize and eliminate target cells with high precision. The first successful use of the CD19 therapy in hematologic malignancy was reported in 2010 by Dr. Carol June and colleagues from University of Pennsylvania, who treated patients with refractory chronic lymphocytic leukemia, and the dramatic response observed in these early trials led to rapidly advances in the CAR T-cell development and ultimately FDA approval in 2017 for the acute lymphoblastic leukemia and other B-cell malignancies. The rationale for CAR T-cell therapy stems from its ability to achieve deeper and longer-lasting B-cell depletion compared to the traditional therapy we use, like rituximab. CD19 is broadly expressed throughout the B-cell development, including plasmablast and short-lived plasma cell, making it a more comprehensive target while also offering a long-term drug-free remission. However, over the past few years, encouraging case reports have extended its relevance to our autoimmune diseases such as systemic lupus erythematosus and systemic sclerosis, and also to the idiopathic inflammatory myopathies, where B-cell dysfunction and autoantibody production play a key pathogenic role in these diseases.
Thank you. Anybody want to
Wow, that's a very comprehensive answer, Maha. I don't think I have Maha really nicely covered from the background all the way to current, and I think I would just like to emphasize one point which Maha nicely covered: the fact that we are getting immune reset, specifically B cell specific immune reset, which we haven't been able to achieve with the previous drugs like rituximab and even perhaps with newer generation, monoclonal antibodies, is the key aspect that for CAR T therapies in myositis.
So I understand why you're saying that. One of the questions, so the rationale in inflammatory myopathies. Being as a pediatrician, I know sometimes the infiltrate is actually a T-cell infiltrate in the muscle. We know there are certainly myositis-specific autoantibodies. Most centers have a whole panel of them. So how does this so are you saying that B cells seem to be more important? So coming back to the rationale.
Okay, if you allow me also, as you know, idiopathic inflammatory myopathies, it's a group of autoimmune disease characterized by chronic muscle inflammation and frequently involve an autoantibody-mediated tissue injury. However, despite the current treatment, which include high-dose steroid and immunosuppressive agent and biologic agents such as rituximab, many patients remain refractory, experiencing persistent disease activity and adverse health outcome, such as interstitial lung disease and severe muscle damage with poor quality of life. B cell contribute significantly to the pathogenesis of the idiopathic inflammatory myopathies through antigen presentation, cytokine secretion, and autoantibody production. CD19 CAR T cell therapy offers novel solution by targeting broader range of B cell population than the CD20 targeted therapy, including the plasmablast, which escape the rituximab-mediated depletion. Recent case reports on the CAR T cell therapy in the idiopathic inflammatory myopathies, particularly in antisynthetase syndrome and also juvenile dermatomyositis, have shown rapid clinical improvement, normalization of the muscle enzymes, and also drug-free remission with manageable side effects. These promising outcomes provide a strong scientific rationale to explore CAR T cell therapy as more effective and durable treatment option for our patients with refractory or idiopathic inflammatory myopathies, demanding further clinical investigation and well-designed clinical trials.
Anything to add?
I would just, again, very nicely put argument, Maha. I would just also add, I think, Carl, you were asking about, what about the T cell, right? And I think the key component that Maha covered, that how B cell is critical in the pathogenesis that seems to be mediated by T cell in the end. It means the tissue injury might be T cell mediated. For example, if you do, muscle biopsies, you're going to see T cells. And if you do lung biopsies in BL, you're going to see T cells. But the critical point that Maha covered is how B cell is actually critical for that T cell to do the effector function. And I think that's very important, including the autoantibody mediated pathogenesis.
Thank you. Yeah. Well, we know rituximab does work. I mean, it's always been a conundrum. I don't think we have the next level, but I think you presented it very well. Thank you. And
I would like to add.
Yeah, go ahead.
Yeah, I would like to add, like, the question about T cells is very relevant because from the literature that we have now on the role of CAR T cell therapy in autoimmune diseases, there were one of the reports of patients with myositis who actually relapsed after taking CAR T cell therapy. And what the authors felt in that patient of antisynthetase syndrome relapsing after CAR T cell therapy was that maybe T cells were the one who were the major predominant pathogenic pathway in that patient, resulting from inadequate response to CAR T cell therapy. So that patient then subsequently required mycophenolate treatment along with CAR T cell therapy to achieve drug-free remission. Though the duration of treatment was small, but definitely there was a role of T cells in that patient.
Doesn't surprise me. We know that we lump diseases together, and any individual can be different completely. So, but it is encouraging that at least their biopsies may be important. Give us some hint of at least some effector end results, but you may be going upstream. So from there, would you like to review the data you presented, data to date on its use, aside from the one patient that we already heard about?
Yes, definitely. I would like to take this question. So the data on the role of CAR T cell therapy in autoimmune diseases and myositis is rapidly developing. I would like to highlight the first case that was reported by the group from Erlangen, Germany, under Dr. George Schett, who reported a case of a 41-year-old gentleman with antisynthetase syndrome with a very bad disease with muscle inflammation, interstitial lung disease, Raynaud's phenomena, high anti-Jo1 antibodies. And as they had given this patient as a courtesy to give CAR T cell therapy. However, the patient responded wonderfully. He did develop mild cytokine release syndrome in the early days after treatment. However, he responded over time with good B cell depletion and T cell activation. And there was improvement in the serological markers, radiographic findings, and clinical symptoms. So after this one report, there have been subsequent many reports in different forms of myositis, like antisynthetase syndrome with ILD, immune-mediated necrotizing myopathies, and even juvenile dermatomyositis. At this stage, with these positive case reports, there are numerous clinical trials that are recruiting patients from all over the world, predominantly in the US, China, and Europe. And even we have one report from the RESET myositis study that is being done in US, where it has shown that patients with IMNM who are supposed to have damage that is significantly more than other inflammatory myositis, responding very well and going into drug-free remission with this treatment. So the evidence is gradually building, but whatever we can see, the pros definitely outweigh the cons given the high risk. And even in patients with autoimmune diseases, I think this is a very good choice.
I would like to add the clinical trials that are going on. Some of the data is not published, but the reports we are getting are very positive, even on the trials that are going on.
That's very encouraging. So that leads to the next question. What is the downside? What are the side effects that we see? Because we are significantly depleting B cells.
Yes, actually, from the results from use of CAR T cell in malignancies, we surely know that this therapy comes with a lot of side effects. The most predominant being the cytokine release syndrome. It is basically like a cytokine storm that happens at the battlefield when the CAR T cells fight the B cells, and there is a lot of ground destruction. This is more so in malignancies because they have a higher antigen load as compared to patients with autoimmune diseases or inflammatory myositis, in which the pathogenic B cells are significantly lesser. However, it is still a major concern where it can lead to severe hypovolemic shock and can be even very aggressive for the patient. Apart from this, there are other side effects that are seen. One is the neurotoxicity known as the ICANS, that is immune effector cell associated neurotoxicity syndrome, which results in neurological consequences of cytokine storm. Other side effects that have been reported have been associated with the leukodepletion that is given before the use of CAR T cell therapy, and it can be associated with thrombocytopenia, anemia, or neutropenia. One of the recently discovered side effects that was recently published in Lancet Rheumatology was LICATS, that is local immune cell associated lymphotoxicity syndrome, which is found to occur in areas where there are pathogenic B cells. For example, if we have a patient of dermatomyositis, then there is hypothesized to be LICATS in the skin and the muscle of the patient. And if you are treating a patient of lupus, maybe the LICATS will be in the kidney, because the lupus nephritis is the one which is the most pathogenic and has the most B cells. So as our data on CAR T cells is evolving in autoimmune diseases, we are understanding the nuances of the side effects that can be associated with this therapy. That is why for clinical trials of CAR T cell therapy, we definitely mandate for a long-term follow-up in these patients to understand these rare side effects, which would not be seen in occasional case reports.
Anything to add?
Yeah, I think nicely put, Anushka. I think I would just add that the burden of side effects seems to be multiple orders less than what we typically hear and see and read in cancer world, specifically hematological cancer, where it's been mostly used. The burden of side effects seems to be related to somewhat tumor burden to large extent, but
Right.
here the tumor burden, so to say, in autoimmunity aspect would be far less. The cell killing will be far less as compared to what we see in oncology. So I think overall what observation is that the magnitude and the severity both perhaps is multiple fold lower in autoimmune disease. But as rightly said, we are basing this on just few case reports. So we need to do proper longitudinal studies in clinical trials with enough long-term follow-up to really say that this is definite.
Yeah.
Right, thank you. Yeah, it's logical that the number of B cells that an autoimmune patient has versus a B cell tumor, could be orders of magnitude. So the cytokine release syndrome, which can be seen with rituximab even. So when you do deplete B cells, we know bigger depletion. But along those lines, one of the things that was worrisome to me was the rare reports of malignancy recurring.
Yeah.
It is somebody who's had a malignancy prior. And to my knowledge, there's no reports yet of that in autoimmune disease.
No, not at all. But
I
that
think it
happens,
also,
but that so happens years later. So
Right. So, and I know I didn't ask this, but maybe you can comment. I know one of the issues was which generation of CAR T-cell receptor was being used. And I know some of the theories are it shouldn't happen with the new generations. So
perhaps we have to see. The newer generations are definitely seems to be better, less toxicity seen even on oncology world. The turnaround time and toxicity profile and infusion reactions are far less. But I think the issue of malignancy has to be looked into with long-term follow-up. I think just saying the newer generation may not cause it or may not have the problem, but that needs to be proven.
absolutely.
well, I also
Yeah, go ahead. Sorry.
Well, I also think that patients of malignancy who are developing a second malignancy are genetically predisposed to develop a malignancy. They have some genetic first hit that makes them susceptible to the malignancy. So that is something that is not seen in autoimmune diseases so easily. The predisposition to develop a malignancy in patients with autoimmune diseases is far lesser as compared to someone who is a patient of lymphoma or leukemia. So I think that is also one of the patient characteristics that define whether a patient will develop a secondary malignancy or not.
We hope.
Yeah.
We hope. I agree. It's exciting. So, but one of the things that intrigued me in your article, you discussed that trial design and response may have to differ in CAR T cell therapy. Could you explain
Yeah.
what the fact was?
Yeah, go ahead. Sorry.
No, go ahead.
Yeah, I'll take that because it's very interesting how the field is evolving. If you would have asked me this question 2 years earlier, I would have said only absolutely, refractory patients who are failed 10 treatments should go in the CAR T type trial. If you would ask me a year earlier, I would have said perhaps, well, 3 treatment failure, severe disease patients could go into CAR T. Since you're asking me today, my answer has changed again. And the answer is we need to at least make sure the patient have moderate to severe disease activity. Reasonable refractoriness, not severe, but reasonable refractoriness. That would mean they have failed at least 2 lines of treatment, total of 3 drugs, including steroid. And also the trial outcome has to be more robust. So, the minimal improvement score, the minimal total improvement score is not enough. At least moderate improvement score, if not major. And perhaps we should also try to look into remission and low disease criteria in myositis. There's some work going on in our group where we are developing remission and low disease criteria. And perhaps that may be a better outcome criteria or outcome measure. But as of now, at least moderate to major improvement of total improvement score. And last but not the least, I want to talk about the length of the clinical trials. Since the response is so dramatic, perhaps the primary outcome could be earlier, 12 weeks, 16 week, or 24 week. But the follow-up, the durability of response is equally important. And that needs to be at least evaluated for the total length of trial, at least 52 weeks, to say that the patient has reasonably improved, but continue to improve and not flared. And the second aspect is, their B cell repopulation, other short and long-term side effects have been adequately evaluated for a trial of 1 year of length. But primary outcome could be even earlier, given the dramatic responses that we see.
Thank you. Yeah, it's very good. Excellent points. I think the future is exciting. We have to pick the patients and do, as we said, look how safe this is. Not only the acute safety, as you discussed, cytokine storm, et cetera, but long-term safety and duration of therapy. And it's exciting, though, going to drug-free remission, for sure.
Absolutely, absolutely.
So anything the three of you any one of you would like to add that maybe we missed that you think is important?
Yeah, I think that one or two aspects that we haven't covered, and I think Maha nicely covered the basics and Anushka covered the data, but I think what has not yet been discussed about is the fact that the patients can be cured, so-called cured, or in remission for years, without requiring the continuous immune suppressive drug, including steroid in many cases, that they can be tapered off steroid as well, is really fantastic. It's transformative. And when you talk to the patients, it really appeals to the patient. Okay, my disease can be, for lack of better word, cured, and may not come back. Now, they understand it maybe, there's always a possibility of flare and relapse. But the fact that they don't have to take the medication is very, very important for most patients. It is a lot of burden for patients to continue infusions and drugs for years and years and years in autoimmune disease. It's almost some patients are on treatment for 50 plus years of their life, which is a lot of burden if you think about it. So this dramatic aspect, transformative aspect, and the fact that they could be off treatment has to be highlighted. I talked about, for example, remission, low disease criteria, and moderate and major improvement. But somebody argued me, and rightly so, that made me think that why do you need such a high threshold of improvement? Why not? How about minimal improvement, but no drugs? That might actually be far more powerful than a minimal improvement on ongoing continuous infusions and 3 other medication. And I kind of understood that argument. I said, okay, maybe that could be the future, but right now we need to still focus on higher thresholds of improvement and more severe disease. But once we prove that, maybe the field may move towards those patients. When we prove it safe and efficacious, then we could move to more lesser disease activity and lesser levels of improvement, but without requiring ongoing treatment.
Agree. Yeah, go ahead.
Yeah, I think I agree with Dr. Aggarwal. I would also like to add, with the development of CAR-T, I think if we are able to switch to an autologous, instead of autologous and allogeneic CAR-T, then it could be something like rituximab, where you take 1 infusion a year, and then you are off treatment for the rest of the year. So that is as good as getting a cure. So I totally agree with him. If we are able to reduce the pill burden to no pill burden and yearly infusions, or maybe 3 years, 4 yearly infusions, that would be something that would be transformative for the patient. Because currently the only drawback is that the waiting time and the development costs and the procedures involved in autologous CAR-T is a restricting factor, which may be overcome with an allogeneic CAR-T.
We hope. I think the cost is an issue here that you brought up. Was the cost of this is high, not that we shouldn't, but it comes back to disease severity and what else do we have to offer people. But I think the point you made always strikes me. If you are drug-free, you feel you're more normal. I mean, it is a psychological burden to our patients with all autoimmune disease or any disease to take medication. It reminds you every day that you're sick. Absolutely. And I think this idea of drug-free, we don't appreciate sometimes psychologically enough, and I hope this will do it. And I hope the side effects are acceptable and the risk benefit. But what intrigues me too, just going back for a second, is I think the idea of having measures of remission, better measure, and low disease activity are crucial. I think when we come to these therapies, we have it in lupus, we have it in RA, we have it in lots of diseases. I think we need it, an acceptable, validated measure of low disease activity or remission, whatever we're going to do.
So, Arl, I'm happy to report that we are putting together a proposal for that, and I think the work is ongoing. We are obviously looking for appropriate ways to. The work has already started on this.
That's fantastic. So I think that's a great uplifting way to end, unless there's anything else somebody would like to add.
No, I think we did very well.
Okay, thank you very much. And I want to thank you, all three of you, taking the time for the interview. And I hope people understand better the rationale, what CAR T-cell does, not only in idiopathic inflammatory myopathies, but the rationale on other diseases where it was used prior to in this disease. And to our viewers and listeners, please read the whole article. It's very interesting to get, again, a more in-depth understanding of the rationale, what is actually being done. And the title is The Role of CD19 Chimeric Antigen T-cell receptor therapy in idiopathic inflammatory myopathies. And it's available at the journal's website at jroom.org and will appear in the June print edition of the journal. I want to thank you for joining us, and I hope everyone will join us next month, including our authors, if they wish, when I speak to the author of another article of interest from the July 2025 edition of the Journal of Rheumatology. And if there are any comments or questions, please send them to us on X at jroom or email to manuscripts@jroom.com. Thank you.